Hello, everybody. Welcome. It's so good to see you. Hi. So good to see everyone. Hello, hello. I am so excited to be here. It's so good to see you. It's so good to see all these beautiful faces. I'm just going to pop in the chat, and Nancy Joe's in California, and Tina's in Maine. I'm getting there, Tina, I swear. And Erica's in Florida. Michelle's from Ohio. Hello, Michelle. And Haley's in Minnesota. Hello, everybody. Um, is it Tana or Tana is in Yosemite? That is a beautiful part of the country. Oh my gosh, welcome. And Christine, I just wanted to say that is so beautiful. She shared that there's a cardinal in her backyard, and she said she bets it's her mom, and tonight we talk about Alzheimer's, and that's what she has. Oh my gosh, I love all of those beautiful messages and messengers that are all around us. And Heather, I see you're back in British Columbia. Hello, good to see you. And we have Dagmar in North Carolina. Arlene says aloha, aloha to you. Welcome everybody. Oh my gosh, what a week. What a beautiful week we have had. How did the homework go? How did the vigil period? Anybody have an opportunity to practice? I see some head nods. I saw some beautiful posts in our Facebook group about sharing that experience and practicing. I just love everyone getting out of their comfort zone a little bit as you begin to spread your wings and share this beautiful message about how we can remind people that dying is a human experience and not a medical experience. I'm so proud of each of you. We have made it to week 7. So, this is your level 2, week 2 training. Last week we covered some we're covering the top 10 disease processes. And so last week we talked about lung cancer, liver disease, and pancreatic cancer. And this week we're going to talk about dementia and Alzheimer's, strokes, colon cancer, and brain cancer. This is a very robust, thorough training. And so today is going to be a lot. So I don't want to spend a lot of time talking. I want to get right into your training, and I have some things I want to share afterwards, but I just want to welcome you. Be sure and grab a cup of tea or some water or any beverage of your choice, and just sit back. You can take notes if you want, but really just take some time to just absorb this information. One of the things that came up, I think it was in our Friday group, and also maybe in the chat. I just want to remind you that this is not like we're not this doula givers or end of life doulas, we're not medical professionals. And so I really want you to not feel pressured about feeling like you have to know everything, that you have to know every single disease process and what to expect. We are not the medical providers, we are the holistic, non medical practitioners that really focus on that non-medical component. And so you don't have to memorize all of this. And I too, I go back. I've been doing this for a while, and I go back to my notes. If I get a client who has a certain disease process, I refer to my notes often. So this is always available to you. You do not have to absorb this and get this right the first time around. It's going to take a while for it to sink in, but remember to I have to remind myself all the time to just drop out of our headspace and drop into our heart space. And that's where we're truly effective. And then just really trusting your intuition. It's so powerful when we can drop into that space. I don't know how many times I've heard nurses and doctors and anybody in the medical field says, "Gosh, darn, if I just would have trusted my intuition," because something's just telling them or us, all of us have this intuitive nature of just like something doesn't feel right. Just trust that. So I really want to empower you as we go along to try not to get too bogged down in the specifics and the disease processes of the mechanics of dying, because we all pretty much die the same way, but there's just certain things that Suzanne shares with us that's really important to kind of tip us off to be ahead of the game in a sense to prepare for tight symptom management. And we'll go into this more and more, but this is just kind of the surface layer of really kind of preparing what to expect with these disease processes. And I do understand that sometimes as we go along with this training, you may have had a prior experience of perhaps someone who had an end of life experience related to one of these disease processes. And I want to honor that and just really just allow yourself some space, because perhaps that experience that you had um, was not the way that you had hoped. And so, really, I just want to encourage you to give yourself some grace that hindsight is always 2020. And really, what you can do is take that information and that experience and step forward confidently into the space to take care of those in your care in the future. So just give yourself some grace as we step into this space. Okay. So again, I'm just going to say I appreciate everybody with their kindness and grace. But I'm going to go ahead and share my screen. And Nadine is on the back end, and she's going to just graciously go ahead and quiet the chat for us. And I'm going to be quiet, and we're going to get started.
Hi, everyone, and welcome to the Certified End-of-Life Doula Training. My name is Suzanne O'Brien. Thank you so much for being here. We are now going to begin Level 2, Module number 3, and I often share, we have so many great pictures now of different groups, and this is one from Florida. It's wonderful when we collectively can get together and work on the same vision of helping people to have a better end of life and share stories. And, one of the things that we really wanted to do was to make a way online to get together live so that we can have everyone be able to take the training from wherever they're located. And so, we do try and get together in person occasionally, and hopefully in the future we will have annual doula giver meetups, which will be very exciting. But this was a lovely group in Florida. And now we're going to start week number 3 in level 2. So we're going to continue on with our top 10 end-of-life disease processes. And it is really beautiful in one sense that we can anticipate and understand the needs of the declining body. So that if you learn the way the body systematically shuts down, we tend to all do that the same way, especially at the very end. But now you're going to learn the pearls, what I call doula giver pearls, of different disease processes. And a lot of things overlap, like a lot of the weakness at end of life will overlap into all of these processes, and the preserving of the energy for your care plans. Breathing issues, a lot of disease processes will have breathing issues earlier with lung interaction, but then later in the process, sometimes that will be apparent, like the liver disease patient where the fluid builds up, like the ALS patient where the diaphragm doesn't expand. So you're going to use your same care plans for breathing diseases throughout anyone who has breathing issues. So you'll get really, again, very good at being able to put together a tailored care plan for your patient. Now, for me, these diseases, they come with nuances of problems and symptoms that really, again, need tight symptom management, and we know that we have a declining patient. So we know that somebody's going to continue to increase in their symptoms. So tight management of that and anticipating ahead of time what we can do to put in place for comfort, because there's nothing worse than seeing a patient have a change in presentation and not having what you need and having to order it. And even if it takes 24 hours to get there, it seems like a lifetime to the patient to the family to you. So we want to, again, look at these disease processes and get a head start on them, get a jump on them to know what we would have to put in place. We can anticipate the needs of that patient, which is really, again, part of the great care we give is anticipating the needs and having it in place before we ever need it, so that things don't get to a high level of an impact on symptom management. So we are going to talk in this module about dementia and Alzheimer's, stroke, colon cancer, and brain cancer. So let's start with dementia. So dementia is, we have Alzheimer's disease, which accounts for about 60 to 80% of all dementia cases. And you probably can think right now of knowing somebody, heard a story, or know of a friend's family, or even your own, that dementia and Alzheimer's has impacted their lives. And when I say impacted, greatly, because these diseases, people don't really understand that they are 24/7 for years, draining emotionally, physically, and financially. So if you know of anyone, if you can think of anyone, and we all can because it's so prevalent. And one of the, there's good and bad news about how long we're living these days. So, the average age of life is 80 years old. That's the average. So I've had patients 106 and patients 5. But because people are living so very long now, we're living with chronic illnesses, and the chances of having debilitating diseases is very, very common and very high. So we want to make sure that people have all the support that they possibly can. And dementia and Alzheimer's is a really big, big issue. So symptoms. So first, the Alzheimer's dementia patient, it affects memory. It affects short-term memory. Then it affects emotions, inhibitions, and daily functioning. Now, I'll tell you that to get an end-of-life diagnosis with an Alzheimer dementia patient is very difficult. It's very difficult to quantify that they are end of life. And one of the main reasons that they will get a hospice diagnosis is because of what you call the weight loss. Measuring of that their eating has diminished, talked about that their eating has completely shut down, but usually it's that they've diminished enough where they're experiencing weight loss in a measurable amount on a regular basis that the doctor can say that they are hospice appropriate. And this can be very tricky. This is very tricky because the way that the Alzheimer's dementia patient is actually kept alive, especially in that latter part of the process where they don't speak, they can't communicate in any way, shape, or form, and they are totally dependent on care, is that they're being fed. And I'm not saying this is right or wrong. I'm just saying that that is the way that people are kept alive, because it is actually a reflex for when it's like when you put a spoon to a baby's mouth and they open the mouth and then they eat, and it's very similar to the Alzheimer's patient. So it's a very tricky one. I know there's been a lot of talk about and there is supposed to be a very specific advance directive that is just for if somebody gets dementia and Alzheimer's, because obviously at that point they cannot speak their wishes and let people know what they want or not want. So that if people do find themselves in a place where they are, totally dependent, have no quality of life, that they wish not to be fed. So it's a very, very tricky one, but it's really important to understand how the progression of the disease is, and it's really intense. It can last 15 years. So first it affects the memory, and it's short-term memory. So a lot of the Alzheimer's patients can retrieve long-term memories. And what I found very fascinating is that music is just wonderful. It's so important to bring music and the vibration of music back into all of our cases and even our lives if we don't play enough music. But for these patients who have been aphasic, so not speaking, and they don't have memory, or they're just like kind of sitting there, a lot of times they'll come to life when a song is being played or sung, that they have known in their past. And especially that, if it was a timely one that really they enjoyed, and it will just melt your heart to see them brighten up for that time. And I've seen people remember all the words to the song. So it's very interesting, that works a different part of the brain. So we just want to remember how it affects people's memory first, and then emotions and inhibitions and daily functioning. And this can get really complicated. So you can have a patient who was the sweetest, kindest person in their whole life get Alzheimer's and become very aggressive and labile and abusive verbally. You can have somebody who is, and it's usually the opposite. So they usually work opposites of what they were like in their um, daily life up until that point of getting that disease. So you can have somebody who was very, oh gosh, I'm thinking of somebody who had frontal lobe dementia. That's a certain type. So there's different types. So this gentleman had frontal lobe dementia, and that strikes actually people who are a bit younger. And he was a very, very, very conservative, reserved man. Um, and he was doing all these things that were like going out and buying, like convertibles, and, talking about sleeping around with different women, even though he was married. And this was never, ever, ever his regular personality. So it can be really difficult for families, especially in that period where, we're not quite sure. Aging does have the memory loss. It's just like a part of aging, to be a bit forgetful, but this is a little different than that, obviously, and it's short-term memory, and obviously the frequency. So you always want to be mindful of, if you're working with family members or whoever, and if it just seems a little bit out of the norm, you want to start really paying attention of the forgetfulness. But the inhibitions, the lack of inhibition, and the emotion changes, you really want to be on top of that as well, and just think how incredibly draining this whole thing can be, especially then the daily functioning, where they're completely, again, 24/7 dependent on care, and that can be really, really difficult physically. So the caused by lesions in the brain, people can live 7 to 14 years after diagnosis, tremendous burden on caregivers. And like I said, this usually falls on one person. There's always like that one caregiver person in a family. This has to be something, I mean, in all, as you can probably see, when we talk about care plans for the end of life for patients, we really want to try and rotate the caregiving, the main task of it, because we want people to be able to have breaks, and we want the main caregiver, the husband, the wife, the daughter, to be able to spend quality time with their loved one, not be doing all the tasking. Well, for this, if you look at 7 to 14 years and somebody doing 24/7 care, I mean, I know people who can't even leave their house because they have nobody to leave their husband with, or, it's really exhausting. So by the time you get them as a hospice patient, as a doula, their family has been through so very much, and that main caregiver has been through so very much. So probably to put exhaustion as one of the things in your care plan, or acute issues, is putting it very, very mildly. So I have a patient story. Her name is Lisa, and she actually at the time was 99 years old, and she had advanced dementia where she really didn't speak at all, and she was bedbound, and she had one daughter that was taking care of her. And like I said, the daughter couldn't leave the house, 24 care. Can you imagine? Again, you have to change the diapers on somebody, you have to change the bedding. It's almost impossible doing it one person. She did have an aide that would come in for 2 hours, 5 days a week, but it was really a lot for her. And it was so interesting because the woman would tell me there were times that she would just break down and just start crying because it was overwhelming to her, the care. And when she did that, she said that her mother put her hand on her head and said, "Don't cry." So for somebody who wasn't speaking, it's kind of like beautiful, these windows that happen. For somebody who wasn't speaking and just sort of staring off most of the days, all the time, when she saw her daughter breaking down and crying, she came to life and she said, "Please don't cry." And so it's interesting, people are in there. And we always have to remember that people are in there. So always be talking to them and trying to reach them. And like I said, the magical thing about music is that it's soothing, and also people will, I can't even tell you how many times I've seen this, people will come to life with songs. So we want to be able to help do that. There's, again, a bunch of different symptoms that you can see with Alzheimer's patients. Usually, again, when you're going to get them as a doula and they're in their last part of life, it's going to be that they're probably not doing much. But up until that point, these patients can be very, very challenging to care for, because they can be walking out the door, um, falling out of bed, getting up. There's really no reasoning with them because of the way that the brain is, the lesions on the brain, and it can be just the most draining, scary, heartbreaking stories. And that's why really have to have multiple people in a family pitching into care and giving people breaks. Stroke. The leading cause of disability in adults, and stroke can cause the inability to speak, swallow, move, and affects memory. So it's interesting because you'll see similarities to the advanced and a severe stroke patient. So there are great, wonderful ways now that if somebody, God forbid, does have a stroke, if it is caught right away, that's why they say if you have any symptoms or think of anything, get to the hospital immediately, because if they can catch it within like the first 12 hours, then there's medication that they can give that will reverse damage and stop the damage from happening, which is incredible. But what we're talking about here is the end stage stroke patient. So people who've had a stroke and within a couple of, it's very severe and they didn't die, but they have been left incapacitated more or less. So again, the inability to speak, swallow, move, and again, affects memory. But a lot of stroke patients, I feel like there's more going on in their brains that they just cannot communicate with you. So it was interesting. I was walking my dog a couple of weeks ago. It was just the spring is just so beautiful with all the flowers blooming. And so we went to Central Park and we were walking through, and I saw a man, definitely looked like a caretaker taking care of a man in a wheelchair. And the man in the wheelchair looked, like he had had a possible stroke or something of that nature, but he was looking at my dog. And so I asked him, I said, "Do you like dogs?" And so, we went over, and Maple, went by him. He couldn't really use his hands, but he was trying to speak, and his eyes were connecting. And so he was absolutely in there and wanting to talk and say things. And so his caregiver was so good, because when we were talking, he kind of knew the answers that the man wanted to say. And so we were sharing that way. So it was, it turns out, which is so interesting, that this man in the wheelchair was a really well-known gastrointestinal doctor in his day. So it was really neat. We started talking about the nutrition and the food. And actually, I feel like Alzheimer's and dementia, I feel that there is a factor with our gut health that affects the disease coming about. And because so many people don't understand, we don't fully know why we have so many dementia cases now. How come people are getting Alzheimer's? And I understand that we're living so very long, so there's going to be a larger amount of people with that. But why? Why is it so much more prevalent? And so I really do believe, through some of my research, that poking around your gut health, you have gut health is really the foundation of your well-being. And when you don't, your gut health really affects everything in your body, especially your brain. So I kind of believe that this has a lot to do with the imbalance of the healthy bacteria in the gut. And it makes sense. We're older. We've been, environmental toxins, food toxins, poor diet, and that we are susceptible to this. So anyway, this stroke patient and many stroke patients will talk to you with their eyes. When you ask them questions, when you talk to them, they're trying to talk back to you. They just can't get the words out because they've lost that ability. So it's so very frustrating for them. Please remember that they're in there. We never want to, because somebody can't make their voice vocal, we never want to talk around them, talk over them, talk inappropriately in front of them. Just try and again, make them part of the scenario without having to respond as much. So it's kind of just a technique, bringing them in. You can even, it depends on where your level of functioning is with your stroke patient. You can even come up with, different kind of signs and symptoms. I mean, signs that they are saying yes or no, blinking their eyes, if they can, squeezing your hand. So there's a way that you can formulate communication. But this can be a very difficult end of life process because of if you lose and people will die because of the inability, once again, to eat, to be able to take in food. And so in the beginning, when you have a very severe stroke, a lot of times you lose the ability to speak and to swallow. So right off the bat, we're faced with a crisis of the stroke, inability to be able to swallow. What do we do for it? So the quickest thing that is done usually is putting in a feeding tube. So that's a tube that goes right into the stomach, that food can be put into that tube. And that's how the nutrition is given, and that's how people are kept alive. So let me tell you a story about a patient, and it's called the feeding tube. So there was a woman who had a severe stroke, and after a couple of weeks of rehab, it was obvious that she was not going to get better. She was not going to regain. So when you have a stroke, it is a brain bleed. And when there's inflammation in the brain, you can lose a lot of your ability to speak, talk, use your hands, your legs, and all of that. But when the swelling goes down, there's a possibility to regain those functions. And so what people like to see is after a couple of weeks, and again, the earlier you can catch a stroke, the better, but wanted to see if there is regaining of the function. And so it was a few weeks after rehabilitation, and then it was said that this woman was not going to be able to regain any of the functioning. And again, she was one of those people that was wheelchair bound, totally dependent, couldn't use her arms, legs, couldn't speak, couldn't swallow, but was in there. Her eyes, she was kind of in there. So she had a son and a daughter, and they were in their late 40s taking care of her. And of course, there was no advance directive. And that's why during this, especially level 3, we'll talk about the real importance of being ambassadors to having people make their own choices. And it doesn't matter what they choose, it's subjective. I always just ask people to make informed decisions that are right for them. And it's our job to really make sure that people know that if they don't make their own decisions, they'll be made for them, and it's usually something that they don't want. So it's really important, obviously, to do that. So this family, this woman did not have an advance directive, and the son and the daughter remember conversations with their mother a bit differently. So what happened here is the doctor came into the room and said that if we don't put a feeding tube in your mom, she will die. And so he kind of threw that out there to the son and the daughter and left. And so they had to discuss it. So it was interesting because, again, no advance directive, nothing in writing, but the son and the daughter both had different memories of having conversations with their mother about what their mother wanted. And so the son said, I talked to mom, and she absolutely talked to me about not wanting any treatments to extend her life if she didn't have any quality of life. And the daughter said, that is not what I remembered. I remember talking to mom, and I feel like she wanted, everything to be done. So they were, again, having this conflict, but it's so important, the advance directive paperwork, the advance directive family meeting before we get to this place, because something very interesting happens when we're faced with crisis, when we're faced with losing somebody we love. We tend to remember things a little differently because we know that if we do not, just like the doctor said, if we do not put a feeding tube in mom, she will die. And sometimes that's all you need to hear in to pull back and say, I remember that she said do everything, even though maybe that's not really what happened. So because they didn't have anything in writing, it was all going on the basis of memory, and they both remembered something very different. So they put a feeding tube in this woman, and the way that you're fed is usually through like liquid canned food. And so she was still in the rehab, in a nursing home rehab, and they would come in and give her the meals in the tube, a couple times a day. And so it was really interesting because the feeding tube, it didn't hurt. It doesn't physically hurt to be fed, but the nurse would come in to give the feeding, and the woman would just tear away and push away as far as she could in her chair and start going like no, no. And so this would happen every time somebody would come in to feed her. And finally the son said, I can't stay here anymore, I can't watch this, this is terrible. So really what was happening is the woman did not want to be fed. She did not want that to continue, because that was continuing her life. And she, I guess to her, had no quality of life at this point, which, really she didn't. There was nothing that she could do or say or anything like that. So the son left, and he took off, and he could not visit his mom for a while. So they told me that the daughter, after a few more weeks, was like seeing this as well and said, okay, we got to take the tube out. And they could not find a doctor that was willing to take the tube back out, because the woman was so old and they didn't want to risk it. So to this day, so the mother died, and to this day, the fighting unfortunately continued between the daughter and the son and the daughter still have a very, very bad, strained relationship, and that's just really heartbreaking. So very important to understand, again, what quality of life means, and hopefully ahead of time, because if somebody isn't able to enjoy any pleasure in life, recognize or talk to anyone or do anything for themselves, it's very important for them to make the decision if that's a way that they want to continue living indefinitely, because we can live for years in this state, for years like this. Is this something, and that's something we all would have to sit down and think and choose for ourselves. Do not leave that on your family. It's not fair for them to decide that. So really important. And if you have parents and you want to talk to your parents about these things like advanced directives, it's so important that you all do that before it becomes a crisis situation. Colon cancer. So about 50,000 people die every year from colon cancer. What I want you to know about colon cancer is the sensitivity to the cancer itself, to the presentation, to the symptoms. So patients can present with rectal bleeding. That's often one of the first signs, is that there's bleeding from the rectum, and that continues with their whole journey to the end of life. And sometimes they can get really heavy. Fatigue, weakness, and constipation issues related to the tumor. It has always struck me how sensitive some of these disease process, because maybe the connection with their body part, or embarrassment, or when there's a lot of blood, so you combine like blood from the rectum, it can be it can be a lot emotionally for the patient. So I want you to really understand the sensitivity around that, and also about people. Some people are, and most people are very, very frightened of blood. So we want to really keep really good protocol with, chucks and diapers and, everything again that can allow for the ease of the patient being able to, if they are alert enough, that they can make sure that they have everything within reach that they need, but then be checking on a regular basis so that there's no big issues. Blood and like blood clots can have a distinct odor. And so again, like a lot of these things, we want to be sensitive to the patient and the people around, and also what we can do to create the best atmosphere so that everyone is having the highest quality of the day. The constipation issues are big, are really big. So when you have the colon cancer and you have a tumor growing in the colon, there's going to be a period of time that the tumor comes back or grows to a point where it's going to block any elimination, and that usually is what is leading right into that transition, going into a deep sleep transition phase, because of the just what's happening in the body process. And when we are blocked like that, it's a situation, if you can't, like a lot of times previously, they will try and remove tumors with surgeries, but they tend to grow back. And there comes a point where it grows back to the point that people now have pain and discomfort. They can't move their bowels and they need a lot of medication to help keep them comfortable. Okay, let's talk about brain cancer. So brain cancer, the symptoms are just almost everything, because you have your brain that's your control center to your body, and any slight shift to that, any pressure, any inflammation, anything will create a bunch of changes in your body. So let's talk about some of the first signs and symptoms will be headache. And my patients talk about this headache, which is pretty much persistent and grows in intensity. And I don't know if you've ever had a really bad headache, but this is something where we have to have tight symptom management and be prepared as best we can ahead of time. So you will see vomiting again on the control centers of the body. Also, high levels of pain with headache can cause vomiting. Vision problems, cognitive issues, behavior issues, personality changes, hemiparesis, so that means paralysis on one side of the body. Again, it depends on where that tumor is, and the tumor's growing, so you're going to see these symptoms increase or more symptoms added. Altered state of consciousness. I want to go back to this for a minute. This is so heavy, and there are two types of the brain cancer that you can see. You can see primary brain cancer. You see brain cancer in a lot of terminal children. So a lot of times there's something called glioblastoma that children will get, and that I had a patient who had a brain tumor, and again, that's a primary source of brain cancer, and then you can have the metastasis to the brain. So we talked about with lung cancer, the organ that it most commonly metastasizes to that type of cancer, if it's going to metastasize, is to the brain. Breast cancer, if it's going to metastasize, there's a good chance that it will go to the brain. So for us, we want to make sure we understand the plethora of symptoms that can go on, and it can just be everything because of your brain is your control center, and when something's touching parts of your brain and growing, everything can be affected, and every day can be different, and it can be really challenging, really, really challenging. So we want to, again, when you see that first one, headache, these are the ones that I really could understand the gentle way that people would want to hasten their end of life, because this is so this gets so complicated. This is probably one of the only ones, and it can be challenging managing these symptoms. You know, these are the ones that have been the most challenging. So let's do a case study. Okay, so you have a 69-year-old female who has suffered a severe stroke 4 months ago. She has not regained any of her functioning. She is total care. This means that she cannot speak, walk, feed herself, dress herself, and is completely paralyzed on the right side of her body, hemiparesis. Her primary caregiver is her husband, Bill, who is 71 years old. This woman is incontinent and is total transfer. She has a hired aide that comes into the home 5 times a week. The aide bathes and feeds the patient, gives her soft foods that the patient will eat if she puts the spoon to her mouth. Okay, so let's see what we have here. When doing this case study, always start with the 3 questions. In addition, what do you know about stroke that will help you with her care plan? What questions might you ask her to help you determine what interventions to suggest for comfort? All right, so we're going to go back and we're going to do the 3 questions. We're going to start with safety. One of the things that we want to be really mindful of is that for stroke patients and dementia patients, that eating is what's keeping them alive. And we want to also know that choking and or food going down into the lung, which can cause pneumonia, is one of the main, those are the main ways, again, that people can have an end of life if they're not at that point where they are not eating and it goes that way, which is, again, how they qualify for hospice. But they will have an end-of-life process if they have aspiration pneumonia, which is food going down the lung, and this is usually caused by inappropriate force feeding or feeding too quickly and not having the patient in the right position, which the right position is sitting straight up, and also being very mindful of your patient. Are they fooling with the food in their mouth? Are they, you know, because they can't tell you they're not hungry because this is just a reflex, and you want to do soft meals. So you want to have that soft consistency for the ease of not choking and for it going down the right way. So really be very careful and mindful of those 2 things. We never ever want to force feed or do it quickly. This has to take time, and we want to watch the reaction of our patient. Are they what you call pocketing food? Are they playing with the food in their mouth? Because this is something that really needs to be addressed. Okay, let's talk about safety issues. We have a 69-year-old female who suffered a severe stroke 4 months ago. She's not regained any of her functioning and she is total care. So 69 years old, yes, so we have an elder who is that is a safety issue. But there's so much more here about safety. So we know now that it's 4 months ago, so she's not regaining any of her function, and she's total care, which means total care. Everything, toileting, dressing, bathing, eating, feeding, everything you can think of, total care. So how do you, as one person, it's virtually impossible, but how do you move like, again, sometimes these people are what you call that dead weight because they can't really help you. They're kind of like not able to do much, so they're that weight that's even heavier than the regular body weight, so it's very, very complicated. So that is safety. She's also paralyzed on one side of her body, so that's a huge safety issue for falling, for everything, for choking, for all of it. So her primary caregiver is her husband, Bill, who's 71 years old. Is that something that's going to be able to continue and be sustainable? An older person taking care of a 69-year-old woman for years? How long did we say that this can last? 7 to 14 years that people can live with stroke and with Alzheimer's dementia if they're being cared for and fed properly. The woman's incontinent is a total transfer. Okay, so safety, safety, safety. She has a hired aide that comes into the home 5 times a week. That's great news. But the aide comes into the house, let's say it's an 8-hour day, Monday through Friday. The aide bathes and feeds the patient soft foods, and the patient will eat if she puts a spoon to her mouth. Okay, so the aide comes in, gets her dressed, cleans her, and feeds her. But then what about all the other times? What about during the night? What about on the weekends? And this gentleman is 71 taking care of her. I don't think this is going to work at all. Let's go back and talk about any acute issues. So really for me, it's safety that's screaming all over this. The one thing that I will say is the woman is incontinent in a total transfer, and she is not able to move or do anything for herself. So an acute issue that I'm going to put on that care plan ahead of time is skin breakdown. That this woman is very susceptible to having skin breakdown because of not moving and being in an incontinent situation and being in the same position until she's physically moved, which will allow for her skin to break down. And we want to be really, really ahead of that. Okay, so nothing else is an acute issue on here. It's all really safety that has been jumping out. And we know that the support system is the aide that comes in and the husband who's 71 years old. So what do you think the first thing that I'm going to want to do when I get in there? So what I'm going to do is talk to the husband about who else, family-wise, neighbor-wise, what can we do to get more help in here for him? And definitely making sure that he is getting some rest. And also, because right now, if we're coming into this at end of life, he has, probably been doing this for a couple of months on his own now, and he might be absolutely exhausted. So let's see what we can do. And again, we really want to take him out of being the primary caregiver, and it's not really appropriate that he could be effectively or should be. I can just see both of them falling down like really easily. It's very, very easy to go to move somebody like this and having them, you all of a sudden lose hold of them because of the way that they're tilting or whatnot, and then both of you go down. This happens all the time. And then what do you think for a 71-year-old man who falls down and possibly this woman fell on top of him? Could he break a hip? Absolutely. So we want to always be ahead of it when we're preventing and doing the 3 questions. So the first thing I'm going to do is really talk to him and see how he's doing, but see who else we have. Who else do we have? What can we pull from? Because this is not sustainable. What questions might you ask her to help you determine what interventions to suggest for comfort? So, again, for me, the real acute issue here is the amount of support that's happening. And then, going from there as far as making sure that people have the safety protocols down for, it really should be a 2-person transfer. 2 persons should be helping to clean and to bathe. Feeding, good technique for the feeding, that I want to make sure that everyone understands what's happening there, that patients should be sitting straight up. They can't tell you if they're hungry or not hungry. You have to really be diligent on watching people. When somebody's eating who's hungry, they chew a little bit, they eat, they swallow, they want more. You can tell when people are kind of just not finishing their food and kind of playing with it in their mouth. So you really want to be on top of it. I'll tell you, these don't go well. These Alzheimer, dementia, and stroke patients for total care for years on end, it doesn't go well. It's heavy emotional, physical, and financial care that is really, really tough to endure. So again, usually when you get a doula patient like this that has these and have been now deemed an end-of-life patient based on the criteria for losing weight, the family's really probably absolutely exhausted and done. So you have to be mindful of all of that. Okay, let's do another case study. You have a patient who's 82 years old and has a terminal diagnosis of primary brain cancer. This patient was just put on hospice care. He lives in a house by himself. His son Alan is his primary caregiver and lives an hour away and works full time. Alan has just hired a full-time live-in aide due to his father's falling 2 times, and there seems to be new cognitive problems. The patient is experiencing short-term memory loss, complaining of head pain, and at times has been using abusive language. When doing this case study, always start with the 3 questions. In addition, what do you know about brain cancer that will help you care for this patient and his family? Okay, let's go back and see what we have in the acute, well, let's do safety. Okay, so we have an 82-year-old man with terminal brain cancer. Is that a safety issue? Yes. Why? Because he's 82. I'm also going to say to myself, brain cancer can affect every ability that we have, and that to me is a safety issue because I don't know. Today the patient might be fine and alert and clear, and within hours or a day the tumor could grow and affect something totally different, where this patient could be, completely forgetful and aggressive and getting up and down, and so I know that we really need to watch super close for safety with the brain cancer patient. This patient was just put on hospice care. Okay, he lives in a house by himself. Is that a safety issue? For sure, that is a safety issue. He has a son, Alan, who's his primary caregiver and lives an hour away. Alan works full-time, but now we see that Alan has just hired a full-time aide. Great for safety, so that's good. Due to his father falling 2 times, and there's new cognitive problems. So there you go. So we're already into that symptom safety issue zone with this patient. The patient's experiencing short-term memory loss, complaining of head pain, and at times has been using abusive language. All right, so I think we're pretty clear here about the the safety issue. We have age, we have brain cancer, which we know is a safety issue. We also have now learned that the patient has fallen 2 times, has cognitive problems, experiencing memory loss. So these are all safety issues. Okay, so let's talk about support system. We have the son, Alan, who's his primary caregiver, lives an hour away, which is wonderful, but he works full time. But he hired a full-time live-in aide. Perfect. Okay. So we're really going to be looking at that aide who's going to be there most of the time as our primary caregiver. And so we're going to really want to make sure that the aide has the education and knows what to look for and how to alert the hospice nurse, and because this can go very quickly with changes in the symptoms. Okay, so we know what the support system is. So let's just look on the other page. Okay, let's go back and see what acute issues there are. So we talked about safety because that's a big one here. So what do we have as far as anything that's acute that needs to be handled right away? Okay, so the patient's complaining of head pain and at times using abusive language. So it's interesting because the abusive language is because of the brain cancer, and is probably something that you're not going to be able to shift because that's what is being activated, that part of the brain. However, it's a really big issue with the caregivers. And it's heartbreaking because, people are just going through caring for their parent, their loved one, and a lot of times, above and beyond and exhausting care, and all of a sudden the parent starts to talk to them terribly and using abusive language and really hurtful. And so you have to make sure that the son, whoever the caregiver is, that they know that that is not them talking, that is the tumor talking. It's hitting a part of the brain. I can't tell you how many times that this has just, again, brought people to tears. They're losing their father or their mother. They love their parent, and they're caring for them. They're giving them their all. And now on top of everything, the parent saying hurtful and hateful things to them. So and they don't really understand necessarily that it's the tumor talking. So you really have to let them know that this is not them talking at all. They don't even realize what they're saying. It can be really something. But you have an acute issue of that head pain, and that is probably going to be one of your biggest things to manage. And it's can be complicated to manage. It can be hard to manage those brain tumors. So I will tell you that you can anticipate that at a certain point there's going to be enough medication on board that that patient's going to be sleeping most of the time, because that's the only thing that keeps them from being in all that agonizing pain. And that comes up with different disease processes. Again, when we talk about the breathing disease processes, there comes a point where the symptom is so high that the pain medicine or the medication needs to increase to combat it, but that level of increase in medication is going to put that patient in what's called a sleeping coma, that they're headed for anyway. It just means that, are they going to get there with suffering and not being able to breathe, or with crazy headaches, or are they going to be gently being able to get to that sleeping coma without being in a suffering state? And I would say that 99.9% of people would say absolutely do not want to be suffering on that level. But we need to let people know that that's a lot of medicine that they're having already, and if that dosage goes up more, they'll probably be sleeping most of the time. And they usually say that's absolutely fine, because when they're not sleeping, they're just screaming in pain. So, but I always want to be really clear about what we can expect, and what do you know is going to happen after you're in a sleeping coma, not eating or drinking for a few days. Usually that's the time when that person will die. So we want to really be aware and help people to understand what things mean, and how unfortunately that's sometimes our only option is that with the brain cancer patient. So that's the acute issue. I want to talk to him about the head pain, what the medication regimen is, and where is that pain level. So on a scale from 1 to 10, where do you want the pain to be? At a number 4 or less. That is the rule of thumb. And keeping that bedside logbook about when somebody was given their medication, you would teach the caregiver this, given the medication, evaluate that patient an hour later, where's their pain level? And if somebody's not able to speak to tell you what their pain level is, you assess from what you see. Are they moaning? Are they wincing? Are they agitated? Do they have burring their eyebrows? Are they having any kind of rapid pulse? Are they sweating? So there's other ways that you can tell nonverbal cues that people are in pain, and that's going to be necessary at a certain point. Why is this pain log important? It's really important for the hospice nurse to be able to evaluate what happens if that and that tumor is going to grow. So what happens if that tumor is growing and causing the pain regimen that had been working fine to not be working fine anymore? You want to be on top of that, and you want to actually anticipate that that's going to happen, because you want to be ahead of it. So you want to make sure that everyone understands that at any time this could need to be changed, and probably will. And sometimes they'll give you orders, like the doctor will order medicine with a range. So giving you that window for the caregiver that they can give more medicine, because they know that it's most likely going to be very needed. All right. So we did the support system, we did the acute issues, we did the safety issues. So this again has safety written all over it, and it's a very complex, brain cancer is a very complex disease process at the end of life. When doing the case study, I always start with those 3 questions. In addition, what do we know about brain cancer that will help you care for this patient and family? Knowing the fact that everything can change, and will, within short periods of time, depending on what part of the brain is being affected. Letting people know that, safety is really important to be watching for at all times. Again, that patient can be fine, and then one day and then the next day be crawling out of bed, or be confused, or be agitated, or just, change in personality. Anything is possible. So safety always has to be on top of the list. But you also want to be with those headaches. You want to be assessing for nausea. you really want to get lots of help in that house if you can, because this can be really intense and exhausting. And knowing that, you know, the medication will probably have to be increased at some point where the patient's comfort is at stake, to the point where they will be in a sleeping coma. So very, very important. And brain cancer can strike people that are young too. I know we talked about children, but just even people, you know, in their 30s, 40s, 50s, 60s. It can also be that primary brain cancer or a secondary. So let's just talk for a minute. What happens if you have a lung cancer patient who is home on hospice with lung cancer? And they're just, you know, they're going about their days, and they're, you know, they're getting a bit weaker, but, you know, not a lot of pain, and everything is pacing activities and things are good. And then one day you come in for your visit and you notice that they're complaining of a headache and that they are acting a bit different, like something is off. Is it necessary and vital that we get an MRI or a CAT scan or any of the above to determine if this person has brain cancer metastases? No, because is that going to change the fact that they are an end stage hospice patient? It's not. However, it's going to clue you in to that you need to prepare for the care plan for the brain cancer patient, because you're seeing the possibility that this is a brain metastases. And so you want to be on top of headache, safety, and all of the symptoms that you may see. So it's not mandatory that you have a definitive exam proving it, but you're going to treat the symptoms that you're seeing. And you know in your training that lung cancer can move to brain cancer as a metastases to the brain organ, that breast cancer typically moves to brain cancer at the end of life. And not always, but if it's going to metastasize, that's the organ that it metastasizes to. So what I want you to not be is shocked if your work, and I haven't had many of these cases at all. I've had mostly you know, people who have their primary brain cancer and primary lung disease, that it doesn't necessarily metastasize, but I want you to be aware of that because of all of those different symptoms that you would see, and you're going to have to prepare for safety, comfort, all of that with brain involvement. All right, so I would teach this to the caregiver, and I would also obviously teach it to the son, Alan. I would see if there's any way to get any more help, even to that main caregiver to give 2-hour breaks where the caregiver, and when I say 2-hour breaks to main caregivers, you know how it is. It's like we're in fight or flight. So we're taking care of that person. We know that they're declining. We know that they're going to die. It's like you're go, go, go. And people, you know, you want to give them a break, but they're like, well, I don't want to go anywhere, and I don't want to go to lunch with somebody, and I don't want to, you want them to even just go in the backyard. Just, you're off duty for an hour or two, go in the backyard, put your face in the sun, just, you know, sit there, have some iced tea, and just do some deep breathing and grounding, and nature's so healing. But we need to kind of encourage them to bring down that stress level that's go, go, go a bit to homeostasis, because they will burn out. People burn out. So this main caregiver, even though he's hired to be the full live-in caregiver, you know, this is a heavy duty case, and I want him to have some breaks too. So maybe even Alan can, you know, take the helm and have the caregiver go out back for a little bit, because you want to keep your caregivers as healthy and supported as possible. And this can be really heavy duty up until the very end, really intense. All right, so your homework for level 2, week 3 is going to be, you're going to have 2 different assignments. The first one is I want you to take your journal, and you have a patient with a new diagnosis of pancreatic cancer. I want you to write in your journal all of the symptoms that you will be looking for with that pancreatic cancer patient. So you can go back into your classroom. You can go ahead and look at all of the symptoms that you will be looking for to assess with your pancreatic cancer patient. I also want you to write down all of the interventions that we talked about for comfort that you will use with a pancreatic cancer patient. Again, depending on what your findings are, but if you don't see all of them right away, you might see one in a couple of weeks from now, a couple of days from now. So you just want to make sure that you cover all the symptoms you'll be assessing for the pancreatic cancer patient, and what are your interventions for comfort. So write down the doula's interventions and also what are the hospice interventions as far as what medicine may be used for comfort. Number two, you have a patient with a new diagnosis of liver cancer. So please write in your journal all the symptoms that you will be looking for and assessing with the liver cancer patient. Remember, we talked about that. You can go back into your classroom. Please write down all the interventions for comfort that you may use with that liver cancer patient. So this is preparing you, because when you get a call that you have a patient, usually what they say is that, hi, we have a terminal patient, or we have a new hospice patient that's looking for a doula. She's female, age 82, and going home with a diagnosis of lung cancer. And that's usually it. And here's their phone number. So what I want you to get into the habit of doing is taking your intake assessment form, which we're going to go over in level 3, where it has all of the information that you can plug in into that template. So that's going to be your patient care template. And what I want you to do before you even step foot in that house is that I want you to know, okay, I have a pancreatic cancer patient. These are what the symptoms are that I'm going to look for, and these are the interventions. I want to know them, and so that I know even before I step foot in that house, I have a loose blueprint of a care plan that I'm going to be putting together. So let's just say pancreatic cancer, we're going to assess for nausea, we're going to assess for vomiting, we're going to assess for pain, we're going to know the emotional component that's attached to the quickness of the diagnosis of pancreatic cancer patient and the prognosis that's usually given 2 to 3 months. It's like, wow, boom, all of a sudden, had some discomfort, went to the doctor, and all of a sudden they're giving me 2 to 3 months. Are you kidding me? So, and that's not just for the patient, it's from the family as well. So there's a lot of emotional component that might stay that way throughout the whole 2 to 3 months because of the lack of a heads up. Maybe people are in their 40s or 50s, early in life. So all those factors will come into play. So I just want you to start practicing what you're going to be doing and how you're going to be thinking before you even step foot in the home of your prospective doula patient. Okay, so we'll go over everything in level 3 about practice and about your templates and your paperwork that you get with your course. It's going to be really exciting putting that all together. You have your next module is going to be level 2, week 4. That is going to finish up the top 10 end-of-life disease processes. You also at that point will get access to your end-of-life doula manual. So you look forward to that. Okay, this is going to be, I want to thank you all for being part of this training, and thank you so much. This was level 2, module number 3.
Welcome back. That was so good. Oh my gosh, I was taking notes. How was that? A lot of information to absorb. Yeah, a lot of information. So we're going to go ahead and open up the chat. Go ahead and just type in hashtag question, if you will. If you want to go ahead and raise your digital hand, we'll go ahead and answer questions live. I'll try to get to as many as possible. I do try to make an effort to answer as many questions as I can. One of the things before I forget, because I will forget, I wanted to mention one of the questions that came up during the Friday meeting about bedside hours. And so I just want to circle back around. We touched briefly, or you may have noticed that in the module 1. So typically we encourage people to start working on their bedside hours after week 4. So we're past that point. I just wanted to give you a gentle reminder. Again, just take a breath. If you haven't started this process, it's perfectly fine. This is not a race on getting all of this certification process completed. But I do want to just give you a gentle reminder that in the module one, at the end of module one, is an explanation about how to get your bedside hours. And then also at the end of module one, you'll see a form on how to submit your bedside hours. And so once you have completed your certification and have completed your bedside hours, then you can turn that in. You'll submit it to support@doulagivers.com, and then you'll be able to sit for the test, and then you'll get your certificate. But I kind of wanted to go over real quickly about the bedside hours requirement. And so you need a total of 15 bedside hours to obtain your certification. And so it needs to be on three different patients. And you actually can use past experience as part as the as far as getting your bedside hours, past experience that can be counted towards your bedside hours. So 15 hours, it would have to be three different patients, and it can be more, but at least three different patients, and only 5 hours maximum per patient. So one person, one of your patients you need to be present for the active vigil sitting. So that's when someone is actively passing away. And this could be a loved one that you've had experience with. And then the next one is you have to be present at the actual time of death. This has to be a separate person. And then the third person is, or just another person having bedside hours. So one has to be at least for active vigil, and then the other one is at an actual death. And then let's see, 15 hours, three people. Where you can get your bedside hours, that's another question. Let me just kind of back up just a little bit to the bedside hours. You can explore doing different places, going to different places. So typically, being a volunteer at a hospice organization is lovely. I do want to give you a little nudge. If you are seeking experience through hospice, I would encourage you to start looking into enrolling into their hospice volunteer program, because that does take a little bit of time. There's some training involved, depending on some have several hours for training, and then also some immunization requirements that are recommended. So immunizations could be measles, mumps, rubella, tetanus. Sometimes a flu shot you can decline those, but they do need either verification of immunization or a blood test called a titer. Um, I don't, it's kind of like you're onboarding as an employee. So I would suggest maybe connecting with hospice companies to see what their volunteer requirements are, and just let them know that you're interested in volunteering. They're looking for some longevity. And I really have to say that if you're going to build a relationship with a hospice company, and if you have several in your area, I would begin interviewing them, not necessarily them interviewing you, but interviewing them, because I think that that could be a really positive uh, uh, feed for you to obtain clients in the future. So there's several doulas that have volunteered with hospice companies that has, it takes some time to develop trust. And as they get to know you and the great care that you're providing, it can really be a win-win situation for both. So there might be a hospice house in your community that you can request volunteer services. NODA, which is No One Dies Alone, which is a great organization. You might want to check to see if there is a NODA in your community. Also, your religious organizations might be a wonderful place to, if you're established with a religious organization, actually letting them know that you are getting your training as a end of life doula, and I'm sure that they could use some support there. Assisted living, nursing homes, independent living. There's also teledoula. So we'll have a training specifically for you at the end, considered your CEUs. But that is something that you can do distance teledoula, so you can support people online. So those are just options I just wanted to go over there. So please don't feel pressured about that. I know you guys are already in the middle of your training, but just feeling like I just want to give you a gentle nudge to consider doing the bedside hours, start working on that. And if you have any questions at all, support at doulagivers.com, but there is information in module 1. So don't feel stressed about it, but just planting the seed that you will need that to complete those bedside hours before you receive your certification. So without further ado, I know I love your glasses. It's Letitia. Yes, good to see you.
Okay. So I don't really have a question as much as I have a couple of comments about some of the symptoms and the pathways that disease process happens with cancer. One of them is that they're finding out that breast cancer actually metastasizes to the lung before it goes to the brain in a lot of women. And the other thing was about the brain tumor. Yeah, I wrote my notes down here. The brain tumor patients, their pain, sometimes they're afraid to say how severe their pain is because they don't want to be medicated because they still have some unresolved issues that they really want to deal with, like waiting for a family member that's out of the country or isn't able to take off from work right away. So it's really kind of a fine line that you have to walk with keeping them as pain-free as possible. And one of the things that I found helpful is to discuss with the hospice nurse or the physician that's making around in the cases that they do, is to be able to give them liquid Tylenol, either an hour to 2 hours after they've had their liquid morphine, because it does help them with the pain. And as Christine said last week, Motrin really helps with the inflammation, and that helps to calm down the pain too. So sometimes the patients can't take one or the other, but anyway, it's a discussion that is good to have with the hospice nurse to make them more comfortable.
Thank you so much for all of that. Yeah, it takes a village, right, to help combat those symptom managements. And I think we can't minimize the use of Tylenol and ibuprofen. I think we feel like as hospice, we kind of need to move into the morphine really quickly, when in reality, maybe some of those other types of medications can be super beneficial. Yeah, thank you so much for that. I appreciate that. I love it. Thank you. I love it. And Antonia, good to see you.
Hi, Christine. Hi, everyone.
Hi.
I wanted to share a little bit about my story really briefly, based on something that Christine said tonight, because both my parents had dementia, and my dad, I just lost my dad 2 years ago, and yesterday was his birthday. So I just wanted to tell a quick little story about my experience based on, I never heard it exactly put this way, that it's difficult to quantify people with dementia as EOL. And weight loss. So just really quickly, my dad was on VNS hospice. VNS is in New York. They're like the best hospice visiting nurse service. I think they're only in New York, but anyway, fabulous reputation. They're really, really big. We had great experience with them. We had him on that in the house for 6 months. And I said to them, I can't have him in the house anymore. It was just too much. Long story. They said to me, he's not active, because I said there's a place called Calvary Hospital that is an end of life hospital, and I said, please let's try to get him into Calvary. And they said to me, they're not going to accept him because he's not actively dying, because he was still eating, talking, walking, all the things. And I basically said to them, I can't do, like, it's got to be me or him that leaves this apartment, because like I can't do this anymore. So I pushed them. I said, just apply, see what happens. First of all, they took him. And second of all, he died 3 weeks later. just like that. Just 3 weeks later, stopped eating, and 2 days later, um, passed 48 hours after he stopped eating. So I was fascinated by this concept of quantifying, like people with dementia and when they're going to die and all that, and also just wanted to share. I tell everybody this that goes through this, like, don't always listen to the experts. This is where the intuition comes in, you know. So I just thank you for letting me share that, Christine.
Oh my gosh, thank you so much for that. I think dementia and Alzheimer's are so hard because it is just this up and down, up and down, up and down, and really the only way that they can qualify for hospice technically is weight loss, and so I've seen people on hospice for a long time, like a long time. And then we think, oh, it's the end. And then they rally and, they stop eating and drinking, they sleep more, and then they pick back up and then they can live. And I've seen people with those diagnoses that actually graduate from hospice. And, it's just interesting, but it can be extremely exhausting and painful for the family members because it's just this emotional roller coaster. And so you're so absolutely right. Like believe the family caregivers, believe the family because they know. And so I'm glad that your dad was supported and that you were supported.
And just the last thing is that it was just so interesting to me. Like, and I will probably never know the answer to this question. Why did in-home hospice say he wasn't ready, and the facility hospice said he was? Deemed that he was. Now he was 93. But like I said, he walked out of here with a walker, walking, talking, eating food. So we never know, you know.
I, I think it depends on the hospice company, and I also think that it depends on, when the RN case manager who does the admit, just the qualifiers and how much information that you can provide to the RN case manager, and then the physician, the ordering physician that deems them qualified. I've seen it go both ways, where one person has been yes, you qualify, or no, that you don't qualify. And then another hospice company says, yes, you do. I don't know. It's not a perfect system. But hopefully there is, there are guidelines that hospice has to follow in actually qualifying. And unfortunately with that diagnosis or that disease process, it can be really tricky. And I'm not, um, um, supporting hospice, but there is a huge amount of fraud that is going on where people are getting admitted to hospice companies,
Mm.
unfortunately, a huge amount. So they're actually very
Oh,
cautious
God.
with those types of admissions because there's a huge amount of fraud going on, unfortunately, which that's a whole nother conversation that we can have about that. But it is happening that people are going to get admitted to hospice and may not quite be qualified yet. So yeah, it can go both ways. So thank you for that, Antonia. Yeah, very good. Hi, Jesse. Good to see you.
Okay, good. This came with low bandwidth. I'm Wendy again, internet problems. Anyway, unstable internet connection. So I had a question. Now you indicated that you could use past experiences for the 15 hours because I've had 4 past experiences, but each like the vigil has to be with a different patient and the death, pronouncing the time of death has to be with yet another patient. So how do you? Okay, I'm going to maybe assume and wrongly at this point. If you shadowed a hospice nurse, which I would still like to do they give some kind of like feedback or anything that you have to have for the class to be considered the 15 hours? See what I'm saying? With if I use what I experienced this last year, how do I document that, or are we just kind of on the honor system?
Yeah, great question, Jesse. So it is on the honor system. And what I would do is I would send a list with description. Try to be pretty specific on the description of the care that you offered with your family caregiver or family members or loved ones. And then just send that to support@doulagivers.com, and then the team will take a look at it to determine if that would qualify for some or
Right.
all of your bedside hours. And I do
Right.
encourage people. To be honest with you, I encourage everyone to do some volunteer work, because supporting people at the end of life looks totally different when you're caring for your person versus caring for someone that you don't have a relationship with. It really helps to broaden the lens a little bit, and there's this state of neutrality that you can have a level of discernment, and there's not an attachment. So I really
Right.
encourage people to please, if even though you've had personal experience, please take that
Yeah.
opportunity for
Yeah.
volunteer. I think it's really important. And
Yeah.
then as far
And
as turning in, what's that?
you're putting yourself out there to,
Yes.
to where they're aware of who you are and what you're doing, and you can connect with other people. Yeah,
Absolutely.
that's all I really had. So yeah, okay, that answers
Good.
that. And
Okay, good. No, so at the end of module 1, I think the last section, there is the volunteer form. So that you can complete, and then you can just scan that to support@doulagivers.com and email it, or you can just snap a picture and then send it to them. But it is all self-reporting. Yeah, you don't need
okay.
a signature. Yeah, great question. Thank you, Jesse. Hi, Tara. Let me see if I can ask you to unmute.
Unmute.
Did that?
Got it.
Yay, we
Yep,
did it.
that
Get
did
it.
it. Hey, we did it this time.
Hi.
So I had a question about that. Well, a quick question, just like kind of two main ones. A quick question about you mentioned Noda. Is that actually still active? Because that's one of the first places I looked. And when I went to their main Facebook page, they said that like since COVID, they were shut down and not working, like not functioning. So I don't know if you heard that are they running right now as far as you're aware? Because that
I
was something I really
am.
wanted to do.
Yeah,
Oh,
so there's NODA, and in each, I think, state or city has their own chapter. So you might have to broaden your search. There's also No One Ever Dies Alone, or let's see, NODA. Yeah. Um, let's see. I always pull up something different for NODA, but um, there is one woman that I talked to that has an incredible organization. Um, I'll have to. It's not coming up on my phone, so I'll post
yeah,
it. I'll make
yeah. You could
notes
share
and I'll put
later.
it in the group.
Yeah,
Yeah. So
because that's
no one
something I wanted to.
ever.
Because yeah, because I started I kind of started with the volunteer thing a little earlier. I started in October just because for me the question of like how am I going to be dealing with real people? I wanted to kind of answer that earlier on in the process. And so I'm like, "Oh, let's just get started." And I lucked out and the local hospice here is just they're angels. It's a nonprofit. I am just so lucky. They're like the best in this whole area, and I lucked into getting in with them. And it is a process because I started in September and it was at least 4 weeks because they do like it's 10 hours of there's a certain like we did 3 2-hour meetings in person, and then there was at least 10 hours of an online training program that we went through as well. And so it was thorough, and I'd already done enough of this that it was sort of familiar. I'm like, oh, yep, yep, yep. This is all great like stuff backing up what we're learning already here. So it was great training. But the issue that I'm having there, and so that's why I was curious about the NODA, is that so I've seen about 4 people now, and trying to get actual vigil and death experience with them Like, I'm not even sure how that's ever going to happen with them because for the most part, like, when it's people, like the couple of people I've had that pass at home with their families, they weren't wanting me there. That was like a family thing. They weren't inviting a volunteer to be present for the death. That was kind of like, you know, and then in the facilities, like, that it's not like I was notified, when things were happening. Like it happened quickly with my first person. She had dementia, and Alzheimer's, and was very advanced. But she went like 7 months. We started to think like maybe she's going to graduate because she just kept trucking on. But then it was interesting that she really did have that up and down. We had a moment where they told me like, well, we think this might be it. And so I went in to say goodbye and to come sit with her because I thought she would be unresponsive. And they're like, yep, she's in the common room chatting it up. She had a big breakfast and she lasted a couple weeks beyond that. And then so when she passed, it was actually sudden. Like when we thought the signs were there that she was passing, she was like, no, I'm not ready. And then when she did pass, we are like, wait, what? So I didn't really get that chance. So yeah, it's tricky with the hospice to kind of figure out how to get that like very end um part. But with the dementia, just really quick, wanted to say too, like it is, Suzanne brought up about like talking to the patients like normally, like making them, even if like they're not responsive. So Joan, my first person, she was word salad. So she couldn't speak back to me. She tried, but it was all word salad. Um but she understood me, and so I talked with her, we had conversation. But it was really, really bothersome that the people, not the hospice staff, the facility staff in the dementia ward she was in, like, I overheard some of them, like, she would talk word salad at them, and they would go, "Oh, yeah, Joan, uppity, uppity, down, down," and, like, talk word salad back to her, and it was like I was so upset for her because 'cause I'm like, "She understands what you're saying. She understands that you just said gobbledygook to her, and that's, like, so offensive," and I just, like, it broke my heart, because I try really hard to make sure that she felt like we were having a both-way conversation and that this was, like, a positive experience. So it's just really important because I know she understood. But anyway, so I'm curious what you've heard about the about like with the hospice, of like how you get those kind of very end hours
So great
satisfied.
question. I would, if you have connection with the social worker and the chaplain in the hospice, if you have a relationship with them,
Oh,
would be
yeah,
they're
yeah,
they're as people are starting to near the end, they're gonna have, instead, because you can always talk to the RN case managers, they're gonna have, the pulse on their patients, but I think the
yep.
chaplains and the social workers probably will have um, kind of an idea, and they're going to be in close contact with the family members. That might be a good resource for you to get connected
That's a
with
good
them.
idea.
And you're absolutely right about our beautiful dementia, Alzheimer's, stroke patients, Parkinson's. It's like they aren't able to articulate and they are very much still there with us. And so, yeah, I've been in numerous situations where people, they're just talking over them and talking about,
Hmm.
things. And I'm just like, oh,
Yeah,
please stop. They can hear you. So
yeah,
it just
yeah,
makes me
yeah.
mindful about how, I tried to just not come from a place of judgment, but
Yeah.
really creating a space for, okay, this is an opportunity for education for people that
Mhm.
may not be aware
Mhm.
that they have the mental capacity to understand,
Mhm.
they're still there. So yeah, yeah. So I'm sure you're doing a
Yeah.
great job, Tara.
Thank
Thank
you.
you so much. You're welcome. You're welcome. Hi, Therese. Good to see you. Oh, you're muted. There you go.
Hello.
Hey.
I just had two quick things. I wanted
Sure.
to mention that as an occupational therapist, I worked a lot with dementia patients. And whenever we would be making a plan of care for discharge, um, we always wanted to know what the goal was. Was if the goal was to like improve, if we sent them to a sniff or a rehab, they would always decline at first because it was an unfamiliar place. And when they have dementia, they usually decline, they stop eating. That was just always something we had to have the family go and help them eat and things like that. That because when they're in an unfamiliar environment, they usually don't keep up with their activities of daily living as much as they do when they're in a familiar environment. So that's just something I just wanted to mention. But also, then I had a question about certifications. So, like I live in Ohio, so the state offers testing for certification. So you can be certified with the state of Ohio. But I'm assuming that's probably not end of life doulas. Am I on the right track? I'm thinking it's probably more for post birth doulas.
So
It's an official test. You have to pay, you have to go sit for the test, and
right,
then you get,
right.
it's not really a license, but it's a state certification. And I believe it's so that you could bill and get Medicaid reimbursement.
Yeah. Yeah. So we're not there yet. We're hoping, I think they're doing
Okay.
some really tremendous amount of work trying to, I mean, it's taken years for birthing doulas to get where they're
Mhm.
at. It's taken
Exactly.
years for massage therapists and acupuncturists to get reimbursed by insurance companies. End of life doulas are not there yet. This is the most robust training certification program there is, but we are
Right.
not certified through the state and we aren't able
Okay.
to bill insurances at this time. But we're really hoping that in the future, as we continue, yeah, that,
That was just what, when I was looking, and then when I got my occupation, I just moved from Virginia back to
okay,
Ohio. And so when I
okay,
was looking, that was one of the certifications that came up. And I was assuming that that was what it was for. I mean, I don't know 100%, but my assumption was that it could, because so they could do billing, they had to have some
yeah.
kind of a state. And I assumed it was for the birthing doulas and that it would have nothing to do with what we were doing.
Yeah,
So,
and I'm not
so
even sure, to be honest with you, if birthing doulas can be reimbursed. I might be completely wrong, but I'm not sure if they are getting reimbursed by insurance companies. I still feel like they might be private pay, but
I'm not sure if it's insurance, but I'm thinking it's more of a government reimbursement through Medicaid
oh gosh,
because,
that's awesome.
yeah, that's where my mind was going. And when I talked to some people, that's where they were going because Medicaid offers sometimes more services than private insurance. And so
Love
with
it.
that, um, that's where I was thinking that that would be it. If you had that, you could bill Medicaid, but you couldn't bill possibly private insurances. But that was what. So I wanted to know if you knew about it, if you were on the same page. That's what I was thinking. So, and there
Can
are
do you
several states that are offering testing. You can test.
will you do a little research
Ohio's not the
and
only one.
awesome. Okay, will you let me know? Maybe post it in the group if you find out anything
I can
more.
always
I'm
call the state. Ohio's not the
okay.
busiest state in the world. It's not like calling California. There's not like,
Okay.
so I
Okay.
believe that I could get answers if I call because whenever I call the occupational therapy, department of licensure, I always get answers. Like they always talk to me. So it's not like a 5-day wait or anything like that. So I will call them and just kind of bend their ear on it because that's what
Okay.
I'm thinking it's going. And I can see end of life doula going that way in the future. I'm thinking 5 to 7 years or something like that. Um, that because I can see the shift and I can see where the insurance companies and also the government would want the people to stay home because I know that the last year of life, how much insurance, that's where the majority of the money is spent on insurance, is the last year of life. And if people would rather stay home, then the insurance companies would rather pay for someone to take care of them at home and help the family take care of them at home than the millions that they're spending in the hospital.
Yeah.
I hate to bring it down to that, but I can see where it would be better for the families, it would be better for the patients if that's what they want, and that it would be an easier shift for the hospital to, or the insurance company to pay that than what they're doing now. So I could see it shifting over that way.
You know, I think at this point anything goes, and
Right. Well, not
that's
in
a
my
whole
lifetime. Like I'm older, I'm retirement age, but like I can see it going there because I've been in medicine so long.
Yeah.
And I can see that it would be actually better for, in my opinion, everyone involved. But if you have the right support systems in place, but you have to
Yeah.
train enough people to be able to support that system.
You know, I'm kind of on the fence, to be honest, and I don't want to take too much time on this, but I'm kind of on the fence. I do feel like, I think that's why I really feel so comfortable with like we have 5 doula givers here in the Treasure Valley where I'm living in southern Idaho, and I just know that all of the folks that have taken this training, like I have no problem referring to this to referring clients back and forth with them because I know how they were trained. I know I just I feel comfortable with the training. Other end of life doula training programs they're all different, right? And so they've all been trained a little differently. And so I think having, you know, I love doula givers because there is the standards of care, there's this code of ethics that we all follow. And so I think that there's just this level of understanding when we're working with the doula givers, there's the standard of care that we all follow. And so, and so, so I understand regulation, but I also understand that sometimes when there's a regulatory body, kind of that these rules and regulations that we have to follow, sometimes things can get a little, challenging. I guess I'll just say that. And so I'm kind of on the fence for yes, there needs to be guidelines and standards of care, but I also feel like that sometimes when insurance companies and you know reimbursement arrangements are made, then sometimes things can get kind of lost in translation, and then we're talking about money over quality of care. So I'm going to zip my mouth on that.
No, I understand because then there would be time restrictions, right? And which is what we don't want. Yes. No, I get it.
So I'm on the fence.
I've been there,
done
that,
yeah.
right?
Yeah. Thank you so much. Oh yeah,
You're
great
welcome.
conversation.
Have a good evening.
Okay. Thank you so much. And there's some, Therese, I noticed that there's some stuff in the chat for you, the Idaho. There's some people were putting some comments in there, so you might want to take a peek at that as well. Okay, we've got a little over. Thank you so much, Therese. Susan, last question. Good to see you.
Okay, thank you. Can you hear me?
Yes.
All right. Hold. Okay. So I just wanted to say that there's an organization I saw that is NOSDAF, which
Okay.
I don't know if you've had it, and it looks like it's pretty national, and it's No One Should Die Alone Foundation. So if I had not heard of that. They also have it where you can volunteer, and they also they have a separate one for veterans. So for just some addition.
Perfect. Thank you. That was what I was looking for. Yep. No One Should Ever Die Alone Foundation. You know, another option for volunteer services is check your local VA clinics, VA hospitals. The veterans need help desperately. So please, please, please consider supporting the veterans and looking for your bedside hours. Thank you for that, Susan, so much. We have gone over. I want to thank you guys all so much. What a beautiful conversation. I'm going to post a couple things as we were in our group about things that came up for me, that just reminding us about the beautiful things that we're learning. And I just can't wait to connect with you guys in the group. Can we take a snapshot picture again? I love seeing all of your beautiful smiles. So on your the bottom or top of your screen, there's the react button that has that heart. Try not to do the one with the effects. And so we're going to go ahead and take a picture. So everyone on my screen, if you can go ahead and put your heart up, and then on the count of 3, we're going to take a picture. 1, 2, 3. We did it again. Good job. I love seeing all your smiles. Okay. Oh, everybody's got the heart up. Okay, hang on. Let's wait for just a second and then we'll do it again. On the count of 3. Okay, go ahead and put your hearts up. 1, 2, and 3. Oh, excellent. Oh, you guys look so beautiful. I love all that. Okay. All right, last one. There's 3 screens. Okay, last one on the count of 3. 1, 2, 3. Smile. Excellent. Okay, everyone, beautiful. Oh my gosh, it's always such an honor. Congratulations for finishing up um, class number 7. I can't believe we're already halfway over. Let's connect in the Facebook group if you want to connect. We're having such a fun time on office hours and happy hour on Friday. Would love to see you then. Let's stay connected in the group and good luck with your homework. And we're here to support you. I wish you guys a fabulous week. You're doing excellent. Good work, everyone. Have a great week. Thank you. Bye-bye.